Cases have been reported in SARS-CoV-2 infections also, and post-COVID vaccinated patients are also reporting with just a minute scotomas.
Madam, what is Purchase retinopathy?
So this happens in trauma, Prushner's retinopathy, peripapillary embolus, small embolus are there. This leads to flecken-like appearance in the retina, post-traumatic patients. So both our patients didn't have any history of trauma, so it was rolled out from the differential diagnosis. So type 2 AMN, this is the main term. Initially we used to know about this term only. It was given by Boss and Dukeman in 1975. It is characterized by acute paracentral scotomas. These were dark wedge-shaped scotoma, and the tip of the dark wedge-shaped lesions and the tip of the lesion used to face towards the fovea. So it shows hyperreflective bands in outer nuclear layer. PAM was an inner nuclear layer. This was told in the outer nuclear layer, more down. So type 2 AMN is mainly seen in young and otherwise healthy women. This is again type 1 and type 2. Type 1 was at the level of inner nuclear layers, and type 2 was at the level of outer nuclear layers. Subsequently, if left untreated, it will lead to atrophy of inner nuclear layers, and this will lead to atrophy of the outer nuclear layers. So what is the etiopathogenesis? It is now postulated that acute macular neuroretinopathy and PAM have distinct ischemic etiology. AMN affects the deep, we have intermediate capillary plexus, superficial capillary plexus, and deep capillary plexus in retina. So AMN is basically affecting the deep capillary plexus and choroid and affecting the outer retina. That's why outer nuclear layers are getting affected. And PAM is basically affecting the intermediate capillary plexus as well as deep capillary plexus. So it affects the middle retina, which is the watershed zone. And why paracentral location? Because it receives lowest oxygen from the choroid diffusion due to thickened retina parafoveally, which is more susceptible to ischemia because parafoveally the retina is more thickened. So these are the lesions of AMN. These are the layers of the retina. So AMN lesions are lower down and PAM lesions are in the middle plexus at the level of inner nuclear layers. The reflectance image, then we can actually appreciate the extent of the lesion. This is a big lesion here also. So this is the OCT. This is showing the lesion at the outer nuclear layer levels. Subsequently, this is the complete hyperreflective area. This we have already discussed. If we don't treat it, it will lead to atrophy of the AMN will lead to atrophy of the outer nuclear layer, and PAM will lead to atrophy of the inner nuclear layers. So currently there is no treatment for PAM. Rather, management is targeted towards identification and treatment of related vasculopathic and systemic risk factors when present. These patients can be anywhere. They can be in derma department with vasculitis, they can be in obs-gynae department, medicine department, cardiovascular department. So suppose any patients come, then ophthalmic references should be done, and now we have OCT also in our department. So over time, these hyperreflective band identified on ST OCT evolve into atrophy with attenuation of the inner nuclear layers and optoplexiform layer, accounting for a persistent scotoma. So with the scotomas which were relative, now if you leave it, the systemic factors, if you leave it, it will turn into a persistent scotomas. So these are few review of literatures. This is a paracentral. This was initially, this term was given by Saraf, and it affects the middle layers of the retina, and type 1 is PAM affecting the inner nuclear layers, and type 2 is AMN which affects the outer nuclear layers. This is again a case report in which a 33-year-old man suffered a cardiac arrest from ventricular fibrillation complicated by prolonged hypoxia and subsequent ischemia to his brain and liver. After regaining consciousness, he noted blurred vision in the left eye. So a diagnosis of PAM was made. When we ran a scan in this patient, there was hyperreflective band-like lesion in these areas. So PAMs are a result of ischemia to the deep and intermediate capillary plexus that supply the outer levels of the inner retina. So these patients can be in ICU treated patients also. They should come for a follow-up in ophthalmic for running a scan and diagnosing this pathology. So these PAM is also reported in primary antiphospholipid syndrome also. And now OPTA, instead of fundus fluorescein angiography, which is an invasive technique in which we put dye and take the images, now we have a new imaging technique called as OCT angiography, which is a non-invasive technique. We type 1 AMN or PAM was originally described in predominantly older men in vasculopathy. But our cases, both the females were young females, otherwise healthy females. So demographic data is not matching. We need, since it is a new terminology and new may be idiopathic and may even develop in young and healthy individuals with an otherwise normal ocular examination. In the setting of PAM with an apparently healthy fundus, appropriate systemic workup to exclude contributing systemic and cardiovascular risk factors such as arterial hypertension, dyslipidemia, or diabetes is advisable. Diffuse lesions, if we have not just one, we have multiple lesions in the retina, then it can harbor an occult central retinal artery occlusion, which is again an ocular emergency and a vision threatening condition. And in such instances, it is mandatory to rule out underlying carotid disease for which carotid Doppler needs to be done, or giant cell arteritis for which ESR and CRP needs to be done. Thank you.
Even central retinal artery occlusion can also be a risk factor.
Yes. So basically, we have two risk factors. One is retinal factors and systemic factors.
Yeah.
So when we have a retinal factors, patients can have ischemic insight in the inner nuclear layers also. So if we treat impending CRVO, whatever ischemia has happened to the patient, it will not revert back.